Good morning, everyone. I'm George Pesarakos. I'm a spinal consultant at the National Hospital for Neurosurgery. And
Jim Greenwood, consultant physiotherapist at Queen Square as well.
so we're here for the very early morning session. And we have the first presenter, Sean Martin.
Good morning, everyone. My name is Sean Martin. I am currently a fellow in stereotactic and functional neurosurgery in Oxford, and my main research interest is in surgery, both brain and spine, for chronic pain. Here's a list of my co-conspirators here. This study has mainly been born from the Neuromodulation Society of UK and Ireland, and we thought this would be some good information to share with the spine surgeons. I think you guys are all operating on the patients that make up the patient population that we want to operate on, and we think it's important that you know what we get up to. So, this is not going on to my next slide. Press next again. Is it a... There we go. So very briefly, what is spinal cord stimulation? So spinal cord stimulation is it's a surgical treatment for chronic neuropathic pain. It's electrical impulses that are delivered to the dorsum of the spinal cord, onto the dorsal columns, via either an epidural percutaneous electrode or through an open laminotomy with a paddle electrode placed over the dorsal columns, typically placed roughly at the lower levels of the thoracic cord for back and leg pain. This little button's not working very well. If you, here we go. Okay. Okay. Why is this relevant to spine surgeons? So the persistent spinal pain syndrome is common. You may know this as the failed back surgery syndrome. It has been renamed. I think the pain societies thought it was a bit pejorative to the spinal surgery community to call it the failed back surgery syndrome, so we now call it the persistent spinal pain syndrome. It's massively undertreated. There are lots and lots and lots of patients that have back pain and leg pain. They've had surgery, they've had decompressions. They're still back in clinic saying, my back still hurts, my legs still hurt, you've not got a surgical target, and they do have a neuropathic component to their pain. These are the patients that we want to see, these are the patients that we want to operate on. So there are about 30 to 40 centres in the UK that implant spinal cord stimulators, and we've all got together and we've made a registry. And this is a prospective registry that collects demographic data on the procedure that's been performed, what device has been put in, and we've used some very simple basic outcome measures. Throughout today, I'm going to talk about the EQ5D utility, i.e. a measure of the patient's essentially quality of life that runs on a continuum from 0 to dead and 1.0 to the best you can be. There is, on the UK EQ5D population match, you can be in a position that is worse than dead, which means you've got severe pain and you can't move. So the continuum runs from minus 0.5 to 1.0. Our data are collected by an independent contractor. It's fully patient reported, it's industry independent, and it's governed by the Neuromodulation Society of the UK and Ireland, and it's been live for about 6 years now. And the Europeans and the Americans are wanting to piggyback onto the back of our data set. This is the data set that we have to date developed. We've got there are about 4,500 patients now on the NNR. Not all of them are SCS patients, but the vast majority are patients that have spinal cord stimulation. I appreciate there are lots of indications other than just the persistent spinal pain syndrome that we use SCS for, but as you can see, the lion's share of patients are those patients that have had lumbar surgery in the past and have got persistent back pain and leg pain, about 2/3 of our patient cohort, and it's nearly 1,700 patients that we've got there. These numbers are slightly unexciting. I'm going to show you a picture in a minute to sort of illustrate this a bit better. But the bottom line is The median quality of life for these patients before surgery is really bad. It's 0.362. Population and age-matched controls would be about 0.8. 6 months after surgery, that improves to, it almost doubles in terms of quality of life, and that's sustained at 12 months. So at 6 and 12 months versus baseline, it's a highly significant improvement. And actually, there's no difference between the 6 and 12-month data points. So this doesn't actually tail off towards long-term follow-up. With a data set that size, you know, with 1,500 patients, not seeing a significant difference and is actually pretty remarkable in and of itself. So this here is showing you graphically, it kind of hits you between the eyes. To the left there, you can see the median utility is the red horizontal line. The quality of life is running from, you know, worse than dead at the bottom to perfect health at the top. Before surgery on the left at 6 months and then at 12 months. So it gets better and improves. Here we're looking at patients. These are the patients that have got paired data, i.e. pre-operative data and post-operative data, and this is the change in their quality of life. So that grey line in the middle is no change. To the left of the line is patients that have got worse after surgery. To the right of the line are patients that have got better. You can see that 3/4 of patients get better after surgery. Looking at the pain and discomfort scores, again, before surgery, 3/4 of patients are saying their pain is severe or extreme. And then after surgery, less than 1/3 of patients are reporting the same. So you can see that movement from low in the left to higher in the right. That's patients' pain scores massively improving with their SCS surgery. I'm not going to dwell on this because I appreciate I'm short on time. I'm blaming it on the clicker. But these are patients specifically that have had lumbar persistent spinal pain syndrome. Really interesting here, actually. We typically in the pain community have always said this works better for patients that have neuropathic leg pain rather than back pain, so that have got dominant leg pain, or patients that have had surgery in the past. So PSPS type 1 are patients that have never had decompressive spinal surgery. PSPS 2 are patients that have. And actually, whether you've got back pain, leg pain, codominant pain, or you've never even had spinal surgery, your outcomes are as good as each other from SCS surgery. And to put that in context, the percentage improvement in quality of life using analogous registry data, comparing SCS with, you know, the big joint registries, the total hip, total knee replacement, they're the only two surgical interventions for painful conditions that are actually outperforming SCS in terms of quality of life improvement. It's better than pretty much everything else, including spine surgery from the BSR, not to cause any competition or anything. I think the bottom line here is that SCS improves quality of life in the real world for patients that are eligible for it, and it works as well or better than many other operative conditions. And I'm going to put this in here because I'm going to leave this up if anyone's interested in having a look at it. So the question really for spine surgeons is, who do you send to us? And the answer to that is anyone with a neuropathic component to their pain, anyone you can't offer further surgery and they've got ongoing pain, send them to a pain physician, send them to a functional neurosurgeon. If there's any question, there is an online tool. You can just click some buttons and it says SCS probably will work or might not work.
Thank you.
That's it.
So that was really interesting work.
Sorry for overrunning. This is a bit dodgy.
Thank you for sharing that with our with the spinal surgeon physiotherapy community. Any questions? We can actually do a whole conference on it, by the way.
We have done as well.
Yeah. No, I mean, from our end. Yeah. Any questions from anyone? So a couple of things for me. So what's the patient? I know the group is obviously very homogeneous, and you would have more granular stats. What's the patient participation in all that? So how many data points you have from, let's say, implantation? 6 weeks, 3 months, 6 months, 2 years, so 5 points, 4 points?
So these data points, well actually this registry we knew was going to be UK wide, so the first thing we did was we made it super simple. So the first thing we've only collected actually was EQ5D. So that's done pre-operatively. I've only included patients that give pre-operative data and ×1 post-operative time point here. So we've got about 2,500 total now. And the data points that we've got are at 0, pre-op, It's 6 months after surgery, then 12 months after surgery.
And what's the participation in that? So
it's-
50%, 80?
Oh, you mean the percentage follow-up?
Yeah.
So the percentage follow-up in ours is 68%. It's actually better than either of the national joint registries. So so the patients that have given a baseline follow-up, 68% of patients have given either a 6 or 12-month follow-up data point. And we've actually done other stats that I've not put in here, where we've imputed a worst-case scenario, where if you say all 32% of patients, which is about 600, 700 patients, if all of those patients were to have an average distribution with the same standard deviation based upon zero change, i.e. everyone that didn't give their follow-up point didn't improve, which is a worst-case scenario, overall, this is still highly significantly beneficial overall.
And one last question, because we're running massively out of time and we
Sorry.
just started. That's all right. It's a very interesting work. Is the long-term follow-up? So you've been running this since 2018.
Yeah.
Do you have anything? I mean, it's known to have the procedure in its various forms does have a problem like ours after a certain point. So 18 months. 24 months. Do you have any data for that? I'm certain for the big cohort for them you would.
There are for some patients, but those cohorts are much smaller. But what I have done with that data set is I've excluded all patients that were implanted after February 2024, so that all patients have had the opportunity to at least give a 1-year follow-up data point. So those numbers are representative of everything up to last year, because there's no point in having someone that was put in 3 months ago. But we do have some data with additional outcome measures, but they're going to be presented and published elsewhere.
Fine. So we'll be waiting for that for the longer term. That's very encouraging. Thank you.
All right, cool. Thanks.
Next one, Ori.
Can we have the next presenter?
Ori Levy.
Okay, let's see if it works. So my name is Ori, as I said, working on the Walton Center, and most of this work was done by Adi. And basically what we are talking about is pseudogout in degenerative spine. Yeah, no conflict of interest to declare. And just a reminder of what's pseudogout. So basically present usually with acute onset of pain, could be with swelling, warmth to the joint. It's very similar to gout. Most commonly affect peripheral joint, could be accompanied by stiffness and reduced range of movement, and it can last from days to weeks, mostly affect people above the age of 60, mostly men, and can be associated with metabolic conditions. Pathophysiology-wise, we've got the position of calcium pyrophosphate dehydrate crystals, and it also leads to inflammatory reaction, synovitis. On imaging X-rays, we can see hypercalcinosis. The acute treatment is usually NSAIDs, steroids, colchicine, which is also the chronic treatment. Joint aspiration can relieve the pain. That's also part of the diagnosis. And if there is any underlying metabolic condition, those should be treated. As for spinal pseudogout, much less common, but maybe because it's just under-recognized compared to the main pseudogout. It's in a large study series, for example, in the trauma case, 500 patients, 12.5% were found to have pseudogout, but looking at the numbers, it's actually 34% in people above the age of 60 and 49% above the age of 80. What we can see in radiology in spinal pseudogout is calcification, joint hypertrophy, and in MRI, inflammatory reaction can mimic discitis or epidural abscesses, and signal voids from the crystals. We'll talk about the motivation in a second, but we've done a systemic review using Prisma, 211 studies initially. Out of those 37 clinical studies, 153 patients. Age range of people with pseudogout was 23 to 83, slightly more female in this cohort. And common comorbidities included hypertension, dyslipidemia, diabetes, cardiac and renal conditions. And areas involved, about a third in the cervical region, 16% in thoracic region, and 50% in the lumbar region. Common radiological findings were non-specific degenerative changes, epidural masses, calcified masses, and common intraoperative finding was chalky white deposit, which I think most people here that would have done spinal degenerative cases can relate to this finding of hypertrophic ligamentum flavum, very wide, very chalky. Most of the patients have done well after surgery. And this is just a few cases from our case series, so you can see different findings like degenerative finding, joint cyst, hypertrophic ligament or hypertrophic joints. Imaging finding, for example, trying to see if I can actually, can't really use that pointer, but that's fine. So what you can see there is a joint cyst. And in this case, for example, we've sent it for histology. It came back as a degenerative synovial cyst, but also deposits of pseudogout crystal, and that was part of the motivation to do this work. And you can see as a finding on intraoperative, but we can't really get to that fine look that everyone would have seen when they operated on backs. But what you can see is hypertrophic ligamentum flavum. Usually, when it's not just a picture, it looks a bit more whitey, more chalky. And this is what we see in histology. We can see the birefringent positive crystals, and we can see also focal inflammatory reaction that's in the area there. Bottom line, why have we done this work? What's the motivation? So most likely pseudogout in the spine is much more common than we think. And the reason to look at that is that maybe we can treat it differently, maybe we can help these people better, maybe rheumatological review, maybe, we usually give neuropathic pain medication for our patients, maybe more of our patients with those findings can have NSAID, for example, colchicine. We need to see with a rheumatologist. So more work need to be done for this large cohort of our patients.
Thank you.
Yeah.
Any questions?
Quite a lot of the time people send off like a facet cyst to the histopathology lab, and it normally comes back saying facet cyst and no evidence of any crystal arthropathy or anything. Do you have to ask the right question to get the right answer? So
yeah, so when we send it, we do ask because we know that we've done quite a few of those cases. So we ask, is there any evidence of pseudogout? And mostly you will find it in the ligamentum. If you send a ligamentum flavum, we all know this appearance of a very hypertrophic ligamentum, very calcified. So if you send this one, this is where you'd usually find it. Yeah.
But do you have to ask them specifically to look?
We do ask on the
polarized light tests.
Yeah. When I send it, I do write, is there any evidence of pseudogout? Yeah.
Also for me, do you feel, what's the take-home message for the spinal surgeons? Do you think the coexisting pseudogout implicates fusion rates, or more importantly, pain outcomes, either VAS scores in pain in back or leg? Do we have any of that data in the literature? I know this was a literature review. Does it confuse the radiology, and we need to make our radiologists a bit more aware? What do you think are the implications?
Yeah. So I think just like the question was, what do we need to ask? So maybe we need to ask those questions when we send a degenerative spine radiology request. Should we ask for that? Are there any findings in keeping with pseudogout? Maybe we should send more histology, which we don't routinely do in spine surgery. Maybe we should send that. And then, it might be that, for example, low-dose colchicine that is being used to prevent further acute episode of pseudogout in peripheral joint. Maybe we should start looking into that. And then maybe we can prevent worsening of our patients, maybe even improve the outcome for our patients.
Thank you.
Next is Lisa Roberts.
Good morning, and thank you to BritSpine for this opportunity. I'm Lisa Roberts. I'm a clinical professor and consultant physiotherapist from Southampton, and I would like to acknowledge the linguist on our team, Katie Roberts, and our funders for this research, the Elsevier and Musculoskeletal Association of Chartered Physios. And we have nothing to declare. Okay. So we know that communication impacts upon every healthcare interaction, and yet despite its importance, there's surprisingly little research that uses real-time interactions in spine care. And analysing recordings is really important because it reduces recall and social desirability bias. And the purpose of this study was to identify the prevalence and impact of minimising language in back pain consultations. Now, minimising is a cognitive distortion that's characterised by reframing events to reduce their significance and can be used to underplay health symptoms, as we'll see in a minute, for softening criticism, for reducing distance between speakers, or also if there are tentative or sensitive questions. So this was a secondary analysis of two studies, a cross-sectional and a longitudinal study, and it comprised 80 primary care interactions. There were 42 initial consultations that were on average 38 minutes and 46 seconds long, and there were 38 follow-up sessions that were 20 minutes and 6 sessions. The patient's mean age was 48, and the back pain duration was 28 weeks, but it was a wide range from 7 weeks to 9 years. And the consultations were audio recorded and analysed by a linguist and myself independently to identify the prevalence and impact of the minimising language. We found 14 words and phrases that were used in a minimising context, and the top 5 are here, in blue by the clinician and in yellow by the patients. And you can see that we absolutely love the word just. It's an outright winner, especially among clinicians. We love this phrase, and we use it twice as often as patients do. We've got an example in our data set where one patient was being in an interaction, and the clinician uses just 11 times during the history taken and 77 times during the physical examination. So here's some examples. There's evidence of where it was used positively in mirroring, which is often seen as an empathic gesture. So here, the physio says, "How's that?" Patient replies, "A bit tender," and the physio comes in, "Just a bit tender when I'm pressing it, yeah?" Or it can be used to reduce distance between speakers. So here in the history taking, do you mind just standing up and showing me where it is when they were talking about pain? We got stuck again. There we go. It can also be used to alleviate anxiety at the start. So here we've got some signposting where the physio says, "We'll just start off with a few questions, find out a little bit about your pain," and so on. And also to reduce effort. So here we've got somebody moving, and this is motion palpation. The therapist has got their fingers on the spine, and as they come back and said, "If you just pop your hands and try and come backwards, any pain in there at all?" And then they said, "No, I'm just going to put a little bit of extra pressure on." Okay. So those interactions, it looks as if it's used quite positively. But conversely, we saw minimising phrases that were followed by an escalation of symptoms, and I'm just going to show you 3 examples. So, the first one is, this is a follow-up consultation, and it starts off, the patient comes in and says, it's actually a bit better. They've been able to sleep better. They've only been disturbed a few nights in the last 3 weeks. And the physio says, "Were you woken up just once or twice?" And then look what happens. We then get the but. And whenever you hear the word but, you're in interactional difficulties. I still have problems. I can't lie on my side. I'm finding it very difficult. So you can see the pushing back is getting stronger. The next one was a straight leg raise test, and the physio comments, "It's a bit tight behind there." Patient pushes back, "It was very tight. I could feel it really stretching." Physio minimises, "I know you're a little bit stiff," and again, a little bit stiff. Patient pushes back, "I'm very stiff." And look what comes next, stiff as an old board. So again, each time it comes back, it's getting stronger. And the final example was some palpation. The person has just been moving, and the physio then says, "I know it's probably going to be a bit tender," and then now if you can bend forward. So they're encouraging them to go into flexion, and look what happens. No, it's not a bit tender. The patient says, "Oh, that's agony. Just doing that. So finally, here are some take-home messages that you can use in your clinic. Minimising can be used as an empathic gesture. However, be careful with words like just, quick, pop, and only. With a patient's permission, you can record those consultations and look at your use of minimising language. It's a great activity for in-service training sessions and for revalidation. And finally, words matter. Patients may not recall exactly what you said, but they will remember how you made them feel. And a really important part of that is your use of minimising language. Thank you very much, and good luck.
Thanks, Lisa. That's fantastic. Any questions for Lisa? No. Lisa, perhaps I could ask a couple. I get the sense when I'm looking at those transcripts that people are trying to downplay the symptoms. And I can see why people might want to do that. We're trying to demedicalise patients. Is there a way we can strike a balance without... We're trying to validate their symptoms but not make the situation worse. How do we strike that balance? What would your recommendations be?
Thanks, Jim. It's a really important point. I mean, I first got interested in this, and it's only anecdotal, when there was a service where, in rheumatology, where patients had, they were doing their annual, patient satisfaction survey. And it was really interesting because there's one clinician in the department and everyone thought, oh, he's great, he's going to make us look really rubbish. And there was a linguist working with them, and they got the results in, and they were much of a muchness. And the linguist said, I've noticed at the end of your consultation, you say to the patient, if you just want to pop your shirt off, we'll have a quick look at your neck, blah, blah, blah. And what was really important, she said, these patients have waited 9 months to see you. Nobody wants a just, a quick, or a pop. He changed nothing about his clinical reasoning and interactions, except he said at the end of the consultation, if you'd like to take your shirt off, we'll have a really thorough look at you. And it's anecdotal, but next time they did the satisfaction surveys, they were really up. So I think we often think, as clinicians, it helps to minimise, and actually it doesn't. It's not helpful in validating. And what we're seeing in this evidence in the data is this significant escalation of symptoms. And you can see, though, where it's really a case of you're not listening to me, and the patients push back, but each time they push back, it gets stronger.
Brilliant. Thanks very much indeed. Next, George McNamee.
Morning, everyone. My name's George McNamee. I'm a physiotherapist based in Coventry. It's a real pleasure to be here to be able to share this work on behalf of the team, where we've looked at who actually is participating in randomised controlled trials that evaluate physiotherapy practice for persistent low back pain. So just some disclosures that a few of the authors receive fees for leading workshops looking at person-centred care and low back pain. Now, we're all very familiar with the prevalence and cause and burden that low back pain carries within society and within the medical setting. But a really important question that we need to ask is who are these people? Who is this population? So data tells us that people with low back pain are more likely to come from areas of deprivation and to be from minority ethnic backgrounds, with these groups being twice as likely to experience low back pain from those from least deprived areas. We know that social factors, like coming from a lower socioeconomic status and lower educational attainment, also have been highlighted as a reason why people don't access or don't receive care for low back pain. And these two are strongly linked to prevalence too. We also know that people with low back pain are more likely to live with 2 or more long-term physical and/or mental health conditions, and with them being strong associations with things like depression and lifestyle factors such as smoking. The bottom line here is that people with low back pain reflect a very, very diverse population, as I'm sure you can all relate to in your clinical practice. What is unclear, however, is whether the participants in the RCTs for low back pain actually reflect this target population. So building upon some previous work that looked at this across low back pain RCTs, we conducted a scoping review with the aim of establishing the demographics and characteristics of these participants but also looking at the eligibility criteria that's applied within these trials specific to physiotherapy. So we included 108 RCTs that were published between January 2020 and June 2024 that evaluated treatments for people with low back pain. Now, we didn't necessarily restrict the intervention that was delivered, providing it was delivered by a physiotherapist. And we also then placed no restrictions on healthcare setting or location to ensure that we got a global viewpoint of this data. So to pick out some of the key findings for you, the mean age of participants was just over 42 years, and with people between the ages of 25 and 50 were included around 80% of studies. So what this tells us is that older populations aren't necessarily participating in these studies. Nearly 3/4 of participants come from a white ethnic background, with just under 25% then representing minority ethnic groups. Now, data shows us that people from Black and Asian groups in particular are more likely to live with persistent low back pain than people from a white ethnic group. We also know that people from minority ethnic groups are more likely to have significant interference with their activities of daily living, yet the studies don't represent this group. In addition to this, nearly 1/4 of RCTs directly excluded people who didn't understand, speak, read, or write the native language of the host country. So what this leads to tell us is that marginalized groups such as migrants are also not represented in these studies. We found that nearly 45% of participants had a higher education course, which is around 15% higher than the UK average. We found that nearly 80% of participants were employed, and only 10% had had an episode of low back pain-related absence from work. This contrasts UK data, where we know that there is a huge population of unemployed people living in the country, but we also then know that there is a growing rise in trends between economic inactivity and ill health. Given the global prevalence and burden of mental health conditions and the well-recognized association with low back pain, it's also concerning to see that more RCTs excluded people for any mental health conditions than for any specific spinal-related condition in particular. Now, we know that this completely conflicts clinical guidelines for low back pain, and we actually only saw that 50% of RCTs evaluated psychological measures of any kind. So what this data clearly tells us is that people at higher risk of persistent and disabling low back pain either don't participate in or are directly excluded from RCTs, and that future RCTs should adopt strategies to ensure that participants are representative of people living with low back pain. Thank you.
Any questions for George? I may take the liberty then. George, absolutely spot on time. Fantastic. Thank you very much. I couldn't agree more. This is absolutely cuts to the nub of the issue. I read RCTs with genuine enthusiasm, and I sit in clinic and I look across the room, and the person that's sitting opposite me hasn't been near an RCT in their life. I can't believe that 80% are in work. That's not the group of people that come and see me at Queen Square. So have you any recommendation for researchers how we increase this breadth of recruitment? I get that there's pressures on power in studies, and power impacts sample size, and sample size impacts cost and duration, and these things are expensive. But how do we square that circle? How do we get more people that are care seekers into trials and keep it affordable and achievable?
It's a really good question, and hopefully Chris later on is going to share some of the work that we've been involved with in Coventry and share some of the data where we very directly only targeted this group of people in particular. And anecdotally, but one of the things that we find most important is engaging with community leaders. And that's a narrative that then has come through some of the talks that we listened to yesterday. What we found is that people either didn't know that we existed or what our role necessarily was in their journey, or they didn't trust us. And I think going out into the community and building that positive rapport with these people, showing that we care first and foremost, and that we have their best intentions at heart, I think is the primary objective. But having patient advocates as well who represent these populations is also really important.
Brilliant. Thanks, George. Wonderful.
Just one more question from me. I find the work really, really interesting, and it just casts a light on how we perform randomized controlled trials, because what you're in essence telling is that it takes the R from the RCT. But do you think there are other restrictions or obstacles in getting that randomization, that representation of the population? One could be more suspicious, and we've seen that in randomized controlled trials in arthroplasties. This would skew the results, including that population that's been excluded. It would skew the results one way. And you've been looking at, we're more in a position to discuss about our community or our population in the UK, but your trials, the scoping review was all over the world. Do you think there's any bias there in the patient selection that's not too related to obstacles, but maybe was a researcher's choice? Are there any stats for that? Or?
Not necessarily stats as such, I think, but I think one of the things that we discussed as a team is the availability of things like outcome measures in different languages. So we know that the vast majority of the studies that featured in this were from Brazil. And if we look at the measures that we used were very particularly given out in Portuguese. So again, it's whether that we have validated outcome measures that can be used for different populations. Again, it's going to be a challenge from a financial and funding perspective as part of that RCT. But again, should then make things more accessible for people who should be included to make sure that we target the right people and make sure that our care is effective for those populations as well.
Thank you.
Thanks, George.
Thank you for coming up. Next presenter, Mr. Nakamami.
Hello, good morning, everyone. My name is Remel. I'm a foundation year 2 doctor in Gloucester Royal Hospital. I'm here to talk about a survey we did in our department. It's regarding patients' perspective about the use of animal-based products in surgery. As you know, animal-based products are indispensable in modern medicine, starting from the catgut that has been used for many decades to the porcine heart valves. And coming to the spinal surgery, you have the products for dural tear repairs, you have hemostatic patches, you have the tissue sealants, you have the bone graft. All of these contains animal-based products. And also, a lot of medications that we use in practice also contains animal-based products. It is said that out of the 100 most common prescribed medicines in UK, 74 of those has an animal-based product. What's the relevance of this topic? UK is becoming increasingly multicultural. Some of the religions object to the use of porcine and bovine materials, and also there's an increasing vegan population in UK that object to animal-based products. And the other thing is, according to the Montgomery principles, the patients do have a legal right to know what is being used on their treatment. And this lack of transparency actually raises a lot of ethical and moral questions. What makes our study unique is that there is no actual article that looks into animal-based products in spinal surgery. And the majority of articles out there actually ask the opinion of the religious leaders on what they think is suitable for patients. And also, there's a few studies in US that looked at the suture materials for patients and what their preference will be. And also, there was a study in Midlands on ENT patients on what they will accept. And the other materials that look into is basically the arguments raised by clinicians who proposes their arguments on the ethical reason for not disclosing to the patients. So materials we use, basically we created a questionnaire. We asked the patients on what will they accept elective surgery if we mention the fact that animal-based products are used? Will they accept emergency surgery, or do they think the information should be included on the consent forms? And the method was basically to bribe the nurse in charge with some chocolates and annoying multiple visits, annoying them to distribute it to patients. We did not have any specific excluding criteria. So our results show that, as you can see in the green, a majority of patients are happy to accept animal-based products. But remarkably, you can also see that a quarter of the patients who will accept would also like to be informed about the use of animal-based products. both in elective and emergency surgeries, and also you can see 5% of the patients have outright said they will refuse the use in elective surgery. And there are a few people that are not sure of the results as well. And we also check about the awareness. About 80% of the population is not aware of animal products being used. And as you can see, we asked the patients, would they like to be informed? A high majority of 75% said that they would like to be informed about the usage of animal-based products. And also, we also asked a question whether they would like this information to be on the consent form, to which 75% also said they would like that information to be included. Just some insights. We had patients ranging from 14 to 91, and the most frequently cited reason that affects the decision was said to be ethical concerns. We also had options like dietary and religious concerns. And the host-derived products were deemed to be the least favorable, and it's not surprised because Gloucestershire is the home to the Cheltenham festivals. And also, the one thing I would like to highlight is that among patients who said they will refuse elective surgery, 40% have said that they will also decline its use in emergency surgeries as well. So this shows that the patients have a strong preference and opinion about the use of animal-based products, and we are doing them a grave injustice by not being transparent or informing them about the use of these products. So what next? So basically, we need to increase awareness among clinicians about animal-based products. We need to organize workshops or training sessions so that we can introduce alternative options to them. And also, we need better methods to identify patient preferences, including like pre-surgical discussions and to integrate animal-based products in consent forms as well. We need to improve communication. As my colleague mentioned just before, communication is really important. So we kind of need to have more studies to standardize the use of animal-based products. And also, I think patient information leaflets will be a good way to start, because sometimes introducing these topics can create unnecessary confusion among patients. So maybe we can give some patient information leaflets which they can read and come back if they have any questions. So just to conclude, most of the patients are uninformed about the use of animal-based products, but the majority of them are willing to accept these products in emergency and elective surgeries, but they just have a strong preference that we have a full disclosure to these products. Thank you.
Thank you. Questions? Okay. Thank you for the presentation. Do you feel, I mean, obviously, bioethic issues are very sensitive and very difficult as well, and in this case, they also implicate the provision of healthcare. Do you feel that to simplify the process, we can have a banner like allergens are present in the restaurant, something like that, so we have they should know with a one-liner that there are implants or processes that have involved animals?
Yeah, so that's a good suggestion. I think that will be a start. I think at the moment, we are, as a healthcare professional, are not giving much importance to these. As I also mentioned, it's not just for the products, because once we start thinking it, as I mentioned before, most of the medications we use, if you come into surgery, the propofol we use is an animal-based product, or even the low molecular weight heparin we prescribe for patients is also an animal-based product. So once we start thinking about it, a lot of changes need to be made at the same time, so there needs to be more transparency on these.
Thank you.
Next presenter, Alex.
Hi, my name's Alex. I'm a physio by training and a PhD student at Keele University. And I'm here to talk about quality indicators for community MSK services as part of a much wider project which has been undertaken by my supervisors at Keele University, who are Jonathan Hill, Roanna Burgess and Anna Banerjee. And I have no conflicts of interest to declare. So as a background, as I mentioned, at Keele, we're currently undertaking a project where we're trying to onboard community services from across the UK into a project that's called the National MSK Audit. And that's a place where many patients with spinal pain or back pain will end up at some point in their care journey. So as part of this project, There's currently 50 services from across the UK which are onboarded and are currently submitting or in the process of trying to submit data to the Keele standardised data collection methods from electronic healthcare record and survey data. So a couple of years ago, when I first started my PhD, we realised that actually when we've got this data, what are we actually interested in? What are the outcomes and the indicators that patients should be achieving within services? And we looked at a range of different indicators, and then when we looked at actually what is routinely collected by these services, actually really wasn't very clear as to how you can implement some of these, for example, NICE measures or Australian back pain standards or arthritis indicators, how you can actually populate them from what has been routinely collected, so patient surveys and electronic healthcare record data. That should not be first. So as I mentioned, the rationale recognised need for quality indicators, the objective that these metrics can be collected through routine data collection. And the end goal is to provide a population health approach focused to optimising outcomes, aiming at reducing health inequalities in community MSK services. And really, the Darcy report that was recently published last year really highlights that actually in community care and in physio services, there isn't this data. There is in primary care, there is in secondary care, but actually what's going on in community care is really difficult to establish. So as part of this project, my PhD, we're currently going through a process to try and establish some indicators that can be used. So I'm here to present the first two parts of this project. So the end goal is to produce something like this, a dashboard that's similar to the National Hip Fracture Database, where you've got indicators or themes, and services can see their own data over time and potentially compared to other services. So in the first stage, which has been completed and published, we undertook a systematic review of quality indicators across primary and community cares for services or conditions, and we synthesised 11 themes across 3 different care quality domains. We also undertook a mapping exercise and mapped these indicators against different messages from MSK directives. Interestingly, and this has been talked about a lot in the last day, we didn't find any indicators from the international literature that could measure the quality of digital tools or services, which with that increase in prevalence in those tools within services, it's a bit of concern. And there was also nothing regarding net zero, which at the minute the NHS is pumping a lot of money into. So we published a systematic review. Following on from that, we've just undertaken a Delphi study, which also been published, and we refined these themes within the team to make them more reflective of for community care services. We did a two-round Delphi study with a consensus meeting in between, and included both patients and healthcare practitioners, which you can see the flow diagram here. So the aim of the Delphi study was to confirm the care quality themes and prioritise the indicators within each care quality theme. So just as a bit of information, so similar to what happens in the National Hip Fracture Database, we have these themes, and within them we have indicators, and the indicators within each theme is weighted to produce an overall score. So participants also had the opportunity to suggest any new indicators within each theme. We've also recently published the Delphi study. So some results. So as a result of this Delphi study and this process we've gone through, and this is not finalised, and we know it's not perfect, but we currently have 6 care quality themes. So the first one around access and assessment, around optimising patient and self-management, optimising personalised care, optimising diagnosis, imaging, investigations and referral, optimising patient outcomes and experience, and population health, which really looks at the severity of patients which are coming to these community services. And you can see we had really good consensus for these themes, and we also had there you can see the number of indicators which are currently within each theme, and an example indicator from within each theme. In the final stage of my PhD, and within the final stage of this project, we know we need to further test these indicators. They're not perfect at the minute. We also need to test them for feasibility when we've got data coming in to the servers at Keele, and that's within a mixed method evaluation in the final stage of my project. And with the end goal, as I mentioned, to produce something which is live, a dashboard that visualizes these indicators that services can use, and it can be used to hopefully drive improvement in our community care services. And that should hopefully be 5 minutes. So thank you for listening. Happy to take any questions.
Thanks, Alex. Any questions? We're really running over, but I just think there should be one point before we close the session. We've heard this morning about underrepresentation in groups in trials and RCT data, and this real-world data absolutely is the key to better representing services from the coalface. What's the next step for your PhD journey?
Yeah, so I think it's also worth mentioning that there is also a challenge even from routine data when collecting this data. You can only tell so much from someone's electronic healthcare record. But in the first instance, you need consent from a survey that they've completed, which is also a challenge to have someone access that which is most commonly at the minute done digitally through a text message or an email, and that can be a challenge in itself. So the next steps for my project is to try and visualize this data into something that can be used, and that really is a challenge at the minute because of the funding which is currently in place for the project which is going on at Keele, which is something which Jonathan and Ro are currently working on. So the current plan is that I'm going to try and test these indicators with some primary care data, which is not ideal, but it should be able to be done. And yeah, that's the next stage, really.
Thank you very much.
Thank you.
Just before you all leave, I've been asked to promote Column and Cord, if you can pick up your copy. And with that, we close this session and thank all the speakers for their excellent presentation.
Good morning. Sorry, we are running about 10 minutes behind, but I'm excited to present a very interesting session to you. As Session said, we're trying to reach out for global spine surgery and have interaction in other countries. So we reached out to the Japanese society, Korean society, Indian society, and they really were very good and agreed to participate for some virtual talks. To minimize the technical problem, we asked them to pre-record the talks and be present for the live Q&A. And 3 of the 4 speakers today are present for live Q&A. One is in the flight at the moment, so they can't. So without taking any more time, let me just first ask them to present Professor Sakai from Japanese Society. If I read his credentials, perhaps I'll take another 5 minutes. So to save time, I'll request you to look it in your app, and we can get on straight to his talk, which is application of augmented and mixed reality in spine surgery and training. Can we play his video, please?
Hello, my name is Daisuke Sakai. I'm the chairman for the JSSR. Today, I would like to talk about application of augmented and mixed reality in spine surgery and training. Thank you for inviting our society for this symposium. So artificial intelligence, augmented reality, surgical robots, virtual reality, all has their roles and in spine surgery. We published this in 2020 where augmented, virtual, and mixed reality, where it has a space in spine surgery or not. So virtual reality is a virtual space. So you can use this system to educate your students or fellows. Augmented reality, you can overlay, maybe say, fluoroscopic image or navigation image onto your head-mounted display so that you can ease your head movement and body turns and so forth. Mixed reality, you can use that 3D image, render it, upload it to the cloud, and download it on your head-mounted display for advanced surgical interventions. So you need to acquire a good image. You need to have someone do the data analysis and make a good image, and then you need an application that uploads and downloads it to the head-mounted display. Well, while these new technology application has rapidly spread in spine surgery, there are some issues as well. So we used the augmented reality first, and then we used mixed reality as a research. and then VR for educational purpose, which I don't want to go into that specific details. So for augmented reality, it's about having not to look at your monitor while you're doing your procedure. You don't want to look, to your monitor so much so that you are moving your eyes off from the patient. Here I'm doing a lateral approach for percutaneous screw placement. This is how it looks from my smart glass, where I'm looking at the monitor through the smart glass onto the patient and not having my eyes off from the patient. It becomes more handy where you are using many screws in AIS surgery, where a very small pedicle, and you are placing a lot of screws. You don't want to, really take your eyes off from the patient. So there was a research from Dr. Matsukawa showing that when you use smart glass, you are moving really, really small, very small number of your rotation of your head while using your surgery. So why not in AIS surgery is what I looked into in this paper in 2023. I looked for fatigue scores and in AIS surgery using or without using augmented reality. So like concentration tiredness reduces with the use of AR. Tired extremities, neck pain, also arm pain also decreases with the use of augmented reality. These procedures promotes more imageless surgery, especially like the complex adult deformity cases using a lateral access. So radiation-free, freedom from scattered radiation exposure is possible. Lateral surgery without the use of fluoro is now become a standard at our institute. You can use the 3D real-time navigation system to size your cage, the approach, the rotation, where it really is crucial for deformity. Also, the use of power tools in reducing surgeon tiredness is important as well. And also, we can now use navigated cages as well for the 5S1. Some people do anterior, but we still do posterior. We can select the appropriate end plate where it's really solid, so that many of the osteoporosis cases are managed adequately. So the next step would be the adaptation of mixed reality systems. How do we use it? So we need first to acquire a good 3D image. Second, we need a good 3D image processing and rendering system and personnel. And then with that, we use the HoloEye system where this program can translate the 3D image that we make outside of the OR, translate it to each head-mounted display systems in their language, and enables these technologies smoother translation. I use the head-mounted display Magic Leap. These are the rendered quality images. Some of the troubles were the quality of the image. I wanted to segment and color it the way I want. I need to train my researchers to do that. And then the speed, you need a good high-speed wirenet in the OR. And you need somebody who understands the pathology for good optimization. So education of the personals that can help you at the OR is really important in doing these technologies. I use this for anterior release for AIS. So when I'm doing anterior approach, I don't want many holes in a young patient. Less incision is really possible by mimicking how do I approach the intervertebral disc using this mixed reality so that I would know the maximal approach that number of discs can be excised from one single incision. Next, I can, in really complex cases, I can overlay that before the surgery or while inside the surgery, during the surgery, so that the complex anatomy is really understandable before I make any kind of incision. And I can plan where I would place my, key screws and where I would do the osteotomy and so forth. Last case would be the OPLL case, very severe. I don't want to push so much on the ossificated region, so I make a 3D model of MRI and also 3D CT, overlay it on the patient before incision, and then I would blend it with 3D CT versus the soft tissue taken by MR, and then download it on my head-mounted display or even microscope to do the procedure. So these new modalities has the potential to reduce patient and surgeon radiation exposure. It may ease the tiredness of the surgeon itself. Mixed reality still is in the way, possesses the limitation needing breakthrough for the image and patient matching. They possess the potential to contribute to the delivery of safer spine surgery. With that, I would like to thank the BAS for this opportunity and open for questions. Thank you.
Thank you, Professor Sakai. I'm sorry, I don't know why the video was a bit jerky, but I'm sure we got the gist of it. I believe you are present for live Q&A. Thank you so much.
Yes, hello.
Thank you for your wonderful talk and giving us a little glimpse as to where you're going. Any questions? May I ask you, we have tried this, you're using Magic Leap, and it's difficult to really merge the patient registration with the image registration. Do you really, you can do it without using the merge between the patient and your head glass, like looking at the patient directly?
Yes, good question. That is one of the major hurdles in using mixed reality onto your daily practice. We do, there are some, new technologies that can enable and maximize the accuracy of that patient matching. But like the anatomical markers and stickers and things like that, we are not still there at the quality of assuring that patients that can prevent patient safety at this point yet.
Thank you. And what do you think is the role in the training then? Means can it use more in the training scenario rather than actual surgery?
Sure. As you can see, visualization of anatomy and also the implants and so forth is quite easy, but the tactile feedback from the patients, like the pedicles or bones and osteotomy, those things are, cannot be modeled by these technologies. So by combination of the actual procedure and the these type of technology can maximize the educational possibilities in our education as well.
Thank you very much. Thank you for your presentation. We'll move on to the next talk, which is from Professor Tamai, and he's talking about role of artificial intelligence in spine surgery. Can we have his video, please?
Hi everyone, this is Coach Tamai from Japan. Today I'd like to talk about the role of artificial intelligence in spine surgery. Here we go. We have nothing to disclose. How can we apply artificial intelligence to provide more effective treatments for spinal disorders, including surgery? Our team believe that to apply the AI to broaden the scope of insights from standard tests without additional expensive equipment, without extra medical costs, and without additional radiation exposure would be the right way to go for. Therefore, we focus on the developing artificial intelligence to identify the abnormalities on brain cervical X-ray. To date, we had the 3 projects. 2 of them have been already published, and another one is under the review. So today, we would like to share our results of these 3 projects. First one is the deep learning algorithm to identify the OPLL on the brain X-ray. For example, this is a 47 years old female. There was mass mixed type OPLL from C2 to C4 using the CT, and now we can see the very clear OPLL on the X-ray film. And our AI suggested that maybe we can see the OPLL around this area. I believe this case is very easy. We don't need to have the help of the deep learning or artificial intelligence. However, how about this case? This is a 56 years old male. There was a very small segmental OPLL on C5 level. Here, on the CT, it would be very easy to identify the OPLL on the CT, but using the X-ray film, it might be very tough for the well-experienced spine surgeon to identify the OPLL on the X-ray film, but our algorithm can do it. And when there is no OPLL cases, the algorithm answered us with the blackout images like that. When we compare the accuracy of the answer, AI algorithm can provide the highest accuracy when we compare the data of the spine surgeon 1, 2, 3, 4 with a very well-experienced spine surgeon. And statistically, there was a statistically higher correct answer rate in the deep learning algorithm comparing to the physician's consensus. Second project is to develop the deep learning algorithm to find the stenosis on brain X-ray. You know, the cervical stenosis is the major concern for especially the elderly patients. However, it would be the very hard task for us, for spine surgeon, to identify the cervical stenosis on just using the brain X-ray. However, our deep learning algorithm can identify the cervical stenosis. And now you can see the MRI and the X-ray film. So it would be very natural to see the stenosis on the MRI. However, our algorithm just uploaded this X-ray film, but it can suspect the stenosis level like that. And in the no stenosis cases, the algorithm also replied us with the blackout images like that. Okay, when we compare the accuracy, when we see the accuracy of this page of this algorithm, using the independent test data set, the accuracy of with 0.81 would be the deep learning results. And when we compare the accuracy and correct response ratio with the 10-spine insertion, that deep learning algorithm can provide the statistically higher accuracy and higher correct response ratio than the real world 10 spine surgeons. Our last project is to identify the osteoporosis on plain X-ray film. That deep learning algorithm designed to detect the T-scores of the femoral neck or lumbar spine less than minus 1.0 using cervical X-ray. And this indicates that the osteoporosis or osteopenia. So this algorithm can suggest that the patient maybe with a cervical disease like a cervical myelopathy or the cervical trauma might have the osteoporosis or osteopenia. And this is the result of our algorithm, that our algorithm can detect the patient with the accuracy of the 0.800 using the independent test data set. In this case, the independent meaning the algorithm do not know the result of the independent test data set like us, but the algorithm can detect the osteoporosis patient with the accuracy of 0.8. When we compare the result with the real-world spine surgeon, as you can see on this table, the accuracy can the deep learning algorithm can provide the highest accuracy compared to the 9 spine surgeons. And this is what we did in the clinical settings 3 years ago. This is a 61-year-old male who underwent cervical laminoplasty for CSM without a prior diagnosis of the osteoporosis. When we uploaded, this is like a trial, but when we uploaded this cervical X-ray to our deep learning algorithm, the algorithm replied us that this patient might have the osteopenia or osteoporosis, so we should check more detailed examination. So we explain these results to the patient, and patient hope to have more detailed examination. So we did the DEXA scan, and DEXA scan revealed that this patient have the T-score of the minus 2.8 in the lumbar spine and minus 2.5 in the femoral neck. This indicates this patient had a very severe osteoporosis. So we treated this patient with medication for the osteoporosis. And after 2 years, this patient has recovered to the normal level of their bone mineral density. So this is a very successful case. And we used our deep learning algorithm like a screening tool of the osteoporosis in this case. So future direction of these 3 projects, we would like to integrate these 3 algorithms into the one application like an DICOM reviewer. This is just one DICOM reviewer in Japan. Now we uploaded many types of the cervical X-ray and run our AI algorithm on the DICOM reviewer. And now you can see that the deep learning algorithm selected 4 images from the 100 cervical X-ray and who might have the abnormality on the indicated level. This would be the one our future direction. And another future direction is to develop the mobile app like WhatsApp. And where we uploaded the picture on the like that, and the algorithm will reply the results. Require further tests, suspected OPLL on C456 level, or suspected stenosis on the C56 level, or suspected osteoporosis. This system might be helpful not only the young spine or young physician, but also the patients. So this would be another way to go for us. Anyway, all of our attempts to apply AI for the current standard examination can expand the diagnostic ability and yield without any additional expense. We hope our researches will broaden the diagnostic horizons of cervical plane radiography. Thanks for your attention.
Thank you, Professor Tamai. That was really interesting and inspiring. Any questions? I take it Dr. Professor Tamai is available on screen. Here he is. Thank you so much. Very interesting. We can see an application where an MR shows query calcified disk. You don't need to do CT. Maybe your application can tell us. Anyhow, William.
Thank you very much for a wonderful talk. I'm just interested in finding out from you whether variations in quality of the X-rays has an effect on your algorithm's outcomes.
Well, thank you so much for a nice question. We converted the Excel film into the JPEG images and the relatively low level JPEG images, but the algorithm can identify the abnormalities on the radiography. That's why I believe the quality of the images must should be higher, and would be the when we would like to have the reliable result, quality should be high. But even if the low quality images, the algorithm can detect the abnormalities on the cervical X-ray film. Thanks so much.
Any other question? So can I ask you, is this available in your country for people to use, or it's still a development phase?
Yeah, thanks for a nice question. Now we are very working hard to be available for this app to everyone, but now it's just a trial. Now we are validating the function, so that it is just before the publication, but not yet. Thank you.
Thank you very much for being present and showing your good work to us. Thank you so much. The next two talks are on the endoscopic spine, and the very first one is from Dr. Sura, who is a very experienced endoscopic spine surgeon from India, Asia Spine Center from Hyderabad. Can we have his video, please?
Hi, good evening to one and all. Today we'll just discuss about feasibility of full endoscopic treatment in thoracic pathologies. Thanks to all these masters who dedicated their life to field of endoscopy, starting from Kembin to Dr. Gore. Dealing thoracic pathologies is always challenging, be it a small prolapsed or extruded disc, calcified disc, foraminal stenosis, or ossified yellow ligament, causing severe thecal sac compression because of the narrow spinal canal. Conventionally, there are various approaches which are very morbid. Either you go interlaminar, posterolateral, or retropleural, or transthoracic, removing the laminae or the pedicle or the costovertebrae to remove a small disc or a small pathology around the nerves. We need to do so much of morbid procedures causing lot of collateral damage, the being a muscle loss or a bone loss or ending up with fusing the spine to remove a small pathology around the nerve, either a disc, calcified disc, or a fibrous disc, or a osteophyte, or posteriorly the ossified ligament. Is there any role of full endoscopy in dealing such pathology? Yes, there is a lot of scope where we can use full endoscopy to review these thoracic pathologies. Credit goes to this professor, Dr. Syed Usman from USA, whom in 1994 first described the feasibility study, and we were fortunate to get trained from him in thoracic pathologies and also in endofusion. He published a paper in 94 about the feasibility study in cadavers when he was in Cleveland about the endoscopy in thoracic spine. In that study, there was a eye-opening anatomical disclosures where the, the exiting route, when we compare to lumbar spine, it is more oblique and downward. And whereas in thoracic spine, it is always upward and outward and goes into the canal just below the upper rib. So here the difference is the exiting route is always away from the working area. So the chance of injuring the exiting route is very less when you are doing a thoracic spine surgery to transforaminal approach. He later published his paper in 2012, two cases where he operated with a two-portal approach through the to the transforaminal area to remove the disc and also fusing the spine endoscopically. What are the challenges in thoracic spine operating through endoscope when you go transforaminally is mainly the rib head, and the foramen is narrow when compared to lumbar foramen. The vertebral canal is narrow, so you deal more with the thecal sac, which is very bulky here. And the disc height is very small. And most of the time, PLL is very thick, fibrous, or calcified. And also, the discs are hard and calcified most of the times. These are the real challenges when compared to a lumbar disc or a cervical disc. The real anatomical challenges here operating thoracic spine through the foramen are the rib head inserts into the disk space. Where you can see in the image the D6, D7 space where the rib head directly uh, inserts into the disk space. So as a result of which, when we want to go through the foramen, rib head is always in the way. When you see this a specimen where D9 below the rib head attaches inferiorly to the disc space, D9 above the rib head attaches into the disc space. So when you are operating a disc in thoracic spine, D9 below, the transforaminal approach is easy, whereas we are operating D9 above, always we need to drill the rib head where we need to be very careful. You can see here the open anatomy where the two transverse processes are exposed, and in the middle the rib head is getting inserted into the disc space. So when we come transforaminally here, the posterolateral approach, we land on rib head and where we need to drill the rib head to enter the disc space. So this is how the trajectory is when we come through transforaminal approach, and we need to use all the tools, either the handheld drills or mechanized drills, or sometimes lasers can be used to open up the foramen widely. There are two approaches to address this thoracic pathology, either through transforaminal approach, which is the best approach, and the interlaminar approach, where we need to drill the lamina and the ossified yellow ligament. So we can, leading to thoracic stenosis, we can go interlaminar way. We just go through the cases of thoracic spine which can be done. So case 55-year female with severe upper back pain and right intercostal pain. So this lady was treated as a psychiatric patient for so many years, but she had a D8, D9 foraminal disc with foraminal stenosis. So in her, I did a transforaminal approach where I entered around 6.3 centimeter after calculating on the MRI. Then I entered there the transforaminal route, but the rib head was coming in the way. So I put a needle where the rib head is coming, and I went there and drilled the rib head dorsally. Then I was able to go inside. Once I went inside, I did a good foraminotomy and pediculotomy to relieve the foraminal compression and remove the disc fragment. The entire disc fragment has been removed and patient is relieved post-op immediately. Second case presented with paraparesis. Here, spastic paraparesis. Patient had D5, D6 stenosis, both front and back, that is ventral and dorsal. But in this patient, the pathology was more in the ventral area with a disc and a calcified hump, so or ossified hump rather. So I went transforaminally here and drilled the here the anatomical variation of a foraminoplasty when compared to lumbar. In lumbar, we drill the superior articular facet first when you're doing foraminoplasty. In thoracic spine, we drill the inferior articular facet first and then the superior articular facet later, because the trajectory we enter is more medial and more oblique, and also the orientation of the facet joint is more like a one above the other, or anteroposteriorly oriented facets. So here we need to drill the inferior facet first and the superior facet later. In this case, both the hand held hollow shavers were used, and also the drill was also used to enter the foramen and enter the disc, and liberal foraminoplasty was done, and the entire ossified hump was removed and disc was removed, and this is a post-op. You can see there is a left side of the patient, well decompressed post-op, and this is a post-op MRI. You can see here the entire foramen has been opened, the thecal sac both ventrally and dorsally has been well decompressed. So case 3 where the patient had a D11, D12 and D12L1 disc pathology, and presented with paraparesis. So again, I went transforaminally here and decompressed the thecal sac, and you can see this is the outcome. This is a I'm not able to run this video. So you can see the post-op decompression. Well, nicely decompress the thecal sac, and patient is relieved of his weakness. And again, case for this patient presented with severe lower limb paresthesia, walking difficulty, and with spastic paraparesis. MRI was showing D10, D11 completely ossified yellow ligament. These are the patient where we can offer a patient a full endoscopic option, because in this patient was a 79-year-old male already operated for cervical myelopathy, both anteriorly and posteriorly. He didn't want one more open surgery. So this patient, I did an interlaminar decompression and drilled the entire ossified ligament. So patient was very happy, and patient improved completely and is being following up and he's fine, doing fine now. This is a post-op. You can see the post-op. Entire calcium has been removed, ossified element has been removed. The thecal sac is well decompressed. Similar case where one more patient came with severe lower limb difficulty with walking difficulty. This patient too had a ossified yellow ligament and also facet capsule ossification. So entire ossified element was drilled where I went interlaminar approach again. Entire area was drilled and post-operatively patient improved. The typical stenosis decompression was done completely. And you can see the post-op MRI, complete decompression. The hump has been completely removed. And one more case, interesting case, patient had a walking difficulty. This patient was operated. Unfortunately, the surgeon thought he just do a decompressive laminectomy, and he did the laminectomy was done inferiorly, missed the level. Again, second surgery was done. Still, the patient, even after removing so many laminae, the patient anterior compression was still present, and patient continued to have paraparesis. So in this patient, I went just 2 centimeter away from the midline, and because the scar was there, I couldn't go transforaminally here because I need to drill the calcium. So I tried going transforaminally, but I entered the pleura. So I came out and just took a 2 centimeter from the midline, just landed at the lateral side, and I drilled the facet, opened up the foramen, and the entire calcium was drilled out. And you can see the thecal sac and ELSA entire ossified. This one has been removed. So patient is relieved, and now patient power is gradually improving. 3 to 4/5 is the power now.
I'm standing on
Slowly
the.
she is walking with some support. So this is a small incision, and this is a previous scar you can see. So definitely thoracic spine is the full endoscopy is a wonderful tool. Definitely we can use it for cases wisely chosen, and especially the disc and calcified discs. It is a wonderful tool. We can avoid fusion. There are limitations of full endoscopy because learning curve is steep, and no one should attempt dorsal endoscopy as a first case. They need to get trained in lumbar. Once they are very well versed, the transforaminal and interlaminar, they have done 50 to 100 cases, then only they should attempt the thoracic spine. Definitely, there is a setting of cost is there for the initial setup. The recurrent cost in the form of disposables is definitely there. And training, because of there is no structured training for endoscopy, we need to push more training programs and training modules so that the youngsters can benefit from this training program. Definitely, there is a lot of scope in the future for spine surgery through endoscopy, where flexible endoscopes and robotics and navigation in spine endoscopy will help to do more safer surgeries in future. Thank you.
Thank you, Dr. Saurabh. Certainly, you're very skilled and brave to get into those territories. I'll open for the question.
Thank you very much for a wonderful talk and wonderful cases that you have shown. Just wanted to pick your brains on the advantage of a retropleural sort of a transforaminal approach versus the traditional transforaminal approach that you showed in your cases, and whether if the pathology is beyond the midline to the opposite side, because quite a number of times the calcified disc is huge, would you prefer one versus the other approach in trying to decompress the whole of the spinal canal rather than one half?
Yeah, so that's a good question. So it's always a thought block that we cannot reach the opposite sides with going from one side. Once you drill the facet completely, you have a very good corridor, and in dorsal spine, the advantage is the interpedicular distance is very small compared to lumbar and cervical. So as a result of which, you can easily reach the opposite side, removing the entire calcium. I've done around 30 cases till now with the dorsal spine ossification, ossified disc. We can very easily reach the opposite side with a transforaminal approach. Only the trick is you need to drill the facet completely wide open so that your pedicle to pedicle drilling will help to see the opposite side better without damaging the thecal side. And drilling the end plate, we call it as a trumpet shape drilling, where we do in cervical spine when we do ACDF. If you can drill the end plates edges properly, then we can go to the opposite side very easily, just lifting off the entire calcified disc or calcified hump easily. We can definitely do from one side to the opposite side without violating any pleura.
Okay, thank you very much. And one last question from me. Position of the patient, lateral versus prone. Advantages, disadvantages.
Yeah, I have not tried the lateral position, though some people in Germany, they do in lateral position. But I am used to prone position because I do most of the cases lumbar in prone. So definitely, I don't have experience in lateral position. I'm yet to try a lateral position in future.
Thank you, Dr. Sura. That was very interesting and helpful presentation. Thank you for your time. And now we will move on to Professor Park from South Korea. He is going to talk about biportal endoffusion.
I am Cheolung Park from South Korea. It is my great honor to have a presentation. These wonderful meetings. Today, my topic is biportal endoscopic translumbal interbody fusion using olive cage. This is my disclosure. And please allow me to introduce by myself. I am one of the main editors for several endoscopic textbooks, including unipolar endoscope and bipolar endoscope surgeries. And also, I have more than 200 cases of bipolar endoscopic transforaminal lumbar interbody fusion using biportal endoscopic approach. Let me introduce the bipolar endoscopic surgeries. Bipolar endoscope surgery is just a knee surgery moved to the spine. So with the hydrostatic press, we can make the working space between lamina and the muscles. So we need two skin incisions. And this we can create the working space between muscles and the lamina bone with hydrostatic gravity or pump. So maintaining good outflow is very important. So to prevent the accident of increased ICP, you have to keep in mind that the normal hydrostatic pressure is 5 to 15 millimeter Hg, and keeping the good outflow. The advantage of bipolar endoscopic TLIP is so we can minimize the soft tissue or muscle damages, and the most big advantage is very good visualizations and the low risk of infection because of irrigation systems. And the basic techniques of this TLIP is the same as a conventional method, including tubular or mini TLIPs. For the TLIPs, there are two types of TLIP surgeries. One is including ULBD or without central canal stenosis. Let me introduce this method, transcambing lumbar interbody fusion with bipolar approach. So, if you need ULBD, you have to stay on the left side because bipolar endoscopic surgeon for right hand right-hand surgeon, right side stand is very, very difficult. So if you need a ULBD, please stand the left side. And if you have a high sacral slope, standing right side is much more convenient. And fixing the angle of CR is also very important before drawing of skins. So true AP angles is very, very important. And for a transcambing approach, because you don't need a ULBD, so skin incision, two skin incision, right side hand surgeons, right side is become working port, more bigger vertical skin incisions, and left side skin incision is endoscopic skin incisions. So from one cm lateral to the pedicle wall is the best place. So you can use these skin incisions to putting the cage and putting the screw. And this endoscopic skin incision, you can use endoscopic port and the screw, also putting the screws. But here, this is a cambium triangle. The basics of this technique is removal of superior articular process and make it wide. So from here to here, lateral wall of dura, you have to make more than 2 cm. If there are more than 2 cm of annulus here, you can put olive cage. So this is videos for olive cages. Hello, my dear friend. I am Park from South Korea. I'm dissecting the facet joint with the finger, and dissecting the lateral part of facet joint with the RF system. This is a bipolar endoscopic surgery. So this is the interspace between SAP and IAP. So next step is the exposure of right side transverse process, because we have to expose the neck over SAP. This is the right side transverse process, and I'm cutting the neck over SAP with the side cutting match stripper, and with the calcium punch, you can cut and take out the tip of SAP. Why? To extend the cambium triangles, and to put big size cage into the disc space, you have to make it down the height of pedicle. So removal of pedicles with the scissors, and partially removal of lateral part of IAP and the inferior part of IAP. And I'm trying to remove all of foraminal ligament. Actually, foraminal ligament, as you know, is a lateral extension of yellow ligament from the spinal canals. And I made the extension of cambium triangle. So you have to check at this time the length of a cambium triangle. Your length of cambium triangle more than 2 cm to put the olive cage. So annulotomy and the removal of cartilaginous and plate under the control of endoscopes. And I'm trying to put olive cage. The biggest advantage of this bipolar system is you can make sure lateral margin of dura here, and also axial area of axial root here. So make sure the safety of nerves. This is trial of olives cages, and putting the olive cage with the oblique directions, and putting into the disc space. The most important thing is that you have to make empty over this space, because we need the seat for space for olive cages. Putting the olive cage with the oblique direction under the endoscope controls. This is the X-ray views for the cage slide, and then we can lay down these cages. This under the safety of nerves, we can lay down oblique insertions and make parallels. This is the post-operative X-rays. Actually, I put 2 olive cages, 34 and 45, including L34 ULBD. This is the actual views. So 34 and L45 ULBD. So only one skin incision, we can put the ULBD and cage incision and screw fixations. This is the final skin incisions and the pedicle screws. I believe this is one of a good method for minimal invasive interbody fusions with the pedicle screw. As we know, there is no need for positional change in the T-lips. So with the T-lips, with the small skin incision, we can put two olive cage. So if we remove S superior articular process here, we can measure the length of annulus from the lateral wall of dura to the inner wall of action root. If the length of annulus, exposed annulus more than 2 cm, you can try the olive cage. So I would like to talk about several important factors. So we can insert our endoscope into the disc space. So removal of nucleus and the cartilaginous endofrate from the pedicle to the contralateral pedicle. So making empty of this space because we have to put a big size cage. So making space is most important. If there are large amount of nucleus remained, you cannot put the big size cage. That is the most important things. And the other important thing is under the endoscope controls, we can make sure that this is a lateral wall of dura here, and here is action root. So under the endoscopic controls and make sure of safety of nerve, we can put the right side cage. And if you make your anatomy more medially, it can cause over retraction of your root because you have to put big size cages. So try to make anatomy laterally, just lateral to sacral sac here. Here is the best space. If you make a more medial anatomy, over retraction, be careful about that. So this is a comparison of a real olive cage and the T-lips. So this is lateral annulotomy and olive cages. And this is after removal of passage joint and put olive cage. I like, this is my cages, which I prefer. This is long picker cage and expander cage with the BMP2 and the real olive cages. And this is a comparison of actual views of MRIs. So, and we can compare the size of footprint. I believe the biggest is more better. And if you need, if you are facing a central canal stenosis, if you need ULBD, your method becomes some changed. So your skin incision is medial pedicle wall. And always your skin is working portable skin incision include the disc space here, and another skin incision for endoscopes, and then you can perform the ULBD and the cage insertion and screw insertion with this skin incisions, and you can use this skin incision for endoscopic port and screw fixation. This is the videos. So briefly, I will explain. So skin incision is very important. With the same method, I like to have a finger dissection, and this is a passage joint. So inferior part of passage joint here, and expose of interlaminar space here. This here is the interlaminar space, and then drillings ipsilateral lamina. So explain the drilling over. I like to start spinolaminar junctions, just like a ULBD. So with the preservation of a yellow ligament, because your yellow ligament must act, you have to remain the yellow ligament, because your yellow ligament will protect the damage from the drill or instrument, the nerve damages. So contralateral, sublaminar exposed. And here is the medial wall of SAP. So the attachment of yellow ligament to the medial wall of SAP is very weak, especially to the older patients. So separation of contralateral, and I am separating ipsilateral IAP and SAP. IAP and SAP separation here. This is a method for angular removal of IAP, separation of passage joint, and here is the pass, the reading of out cortical bone pass, and the breakage of pass. breakage of pass. And you can take it with one piece of IAP like this. You can use this large piece of IAP for autograft. This is lateral, ipsilateral medial wall of SAP. And you have to remove the tip of SAP, just like the Canbin triangles. So we have to make extend the Canbin triangle, just like this. And from this lateral wall to the here, if there are more than 2 cms annulus, you can put only cage. And I like to have annulotomy from the lateral to the medial direction, and the removal of end plate cartilage till the anterior part of annulus, because we can put our endoscope into the disc space. So one of the biggest advantages is that we can make a wonderful fusion bed. And I'm putting the expandable cages. This is the expandable cages with and the BMP2. And this is the autobones. So this is a post-operative X-rays. So we can compare the expandable cage with the BMP2 and also DBM with the Pico cages. This is same patient, 6 months. So this endoscopic fusion surgery is not yet reached inflated expectations. And the paper for bipolar endoscopic fusion is rate is very increasing and very hard currently. Endoscopic transforaminal interbody fusions could become one of the good methods for interbody fusions with a well visualization and minimize soft tissue damages and low risk of infection. By multiple level interbody fusion, we prefer to have only interbody fusions. Thank you very much for your kind considerations.
Thank you, Professor Park. As I said, he's on the plane to the Japanese meeting, so he won't take any questions. We're running late.
Good morning, everyone. So we're running a little bit late, but we'll try and see if we can get the best out of this session. So I just want to give you a background. The background for having this debate was an approach by one of our AHP, I think, or a physiotherapist who I think approached us in Bournemouth, pointing out that the BAS leaflet about stenosis and the comments about physiotherapy may be misleading. So we are here today to just work out how we can work together to improve outcomes for our stenotic patients. Jim?
Morning, everybody. So we're going to go in the order 1, 2, 3, and first up will be Esther Williamson, followed by Susie McElroy, and then the surgical case will be presented by Ashley Cole. So without further ado, Esther.
Thank you. My name's Esther Williamson. I'm a physiotherapist and I'm a researcher at both the University of Oxford and Exeter. So I guess we're probably not really thinking of this as a debate, more as a discussion to have a think about what the role of physiotherapy is from both our perspective as physiotherapists, myself and Susie, and then to hear about the surgeons' ideas, and let's see how where they differ and maybe whether they're the same. So in terms of the role of physiotherapy in management of spinal stenosis, yes, I think there is definitely a role. And I think we have a really important role in supporting older people to manage the symptoms that they have of spinal stenosis. And this is throughout the whole care pathway. So the aims of physiotherapy will change depending on the patient needs, but also the stage of treatment that they're at. And we all need to be providing the right care at the right time. So we suggest that actually this is a kind of what we would call a stepped care approach, in that we start with self-management, where people get good quality advice about exercise, increasing physical activity and managing symptoms. And then those that need it move on to more intensive rehabilitation. And then obviously there are surgical options and then the post-surgical phase as well. But what is really key to this and providing good care for our patients is actually that there's communication between the surgeons and the physios, that we have a way where we can monitor symptoms and be able to refer on, but also if someone is referred for surgical opinion, that they can be referred back for rehabilitation if required. So in terms of self-management, we know that symptoms of spinal stenosis affect an awful lot of older people. So the work that our research team has done to look at the prevalence in the community dwelling population, we know that about 11% of older people will report symptoms that are consistent with spinal stenosis symptoms. And it can be extremely disabling. It's associated with frailty, falls, and mobility decline. So it is a really problematic condition. But we also know that natural history does suggest that about a third of patients will improve over time, about 55% will be unchanged, and then there are a percentage that will worsen. We know that some patients can self-manage and that they actually providing good quality advice is sufficient for them to help manage their symptoms. So our team have done a large randomized controlled trial looking at the management of spinal stenosis. And this was for people that were not on a surgical waiting list, so they weren't surgical candidates. And the control arm of this trial was good best practice advice, was what it was called. And this was essentially what we're talking about here, was good quality advice around managing symptoms and increasing exercises and physical activity. And for some of our participants, this was sufficient. And you can see on the screen there's a couple of quotes, that information empowered people, it reassured people, and giving some simple exercises actually could be used as a way to relieve symptoms. So we would suggest that good quality self-management advice, as a first step, allows the provision of more than intensive rehabilitation programs for those that need it. And physiotherapists are ideally placed to provide this information and advice. Some patients will require more intensive rehabilitation. And this might be because some patients actually aren't suitable for surgery or don't want to have surgery, and there needs to be other options for these patients. From the literature, there is moderate quality evidence that multimodal approaches that include different facets of physiotherapy, such as manual therapy, exercise, education, are safe and effective treatments for people with neurogenic claudication. And in our BOOST randomized control trial, where we tested out a psychologically informed rehabilitation program, we demonstrated improvements, particularly in walking, physical capacity, and reduction in falls, which are all really important outcomes for older people. Improving pain can be challenging in this population, and we won't, shy away from that. So some patients will require further assistance. And this is where we really need to have that good level of communication between physiotherapists and surgeons to ensure that patients are seen in a timely way, that there's a way that we can get patients for surgical opinions when needed, but also, as I said earlier, keeping in mind that actually what we also want to see is happening is when patients go for surgical opinion and surgery is not an option, that they're coming back then to have good quality rehabilitation. And we're going to move on to surgery, and so I'll pass the baton to Susie.
Okay, so hello, my name's Susie McElroy. I'm a physiotherapist at King's College Hospital, and I'm going to talk about the next two sort of areas where we think there is a strong rationale and role for physiotherapy in the management of patients with lumbar-spinal stenosis. So it takes us on to patients waiting for surgery for lumbar-spinal stenosis. So patients have an extremely long wait for surgery, and they feel like their life's on hold, it's in limbo. And they're very anxious. They're often seeking information about their condition, about their surgery, what they can and they can't do. And they report searching the internet, searching for information about what they safely can do. But they're very dissatisfied with what they can find, and this really raises their anxiety levels. Furthermore, they're fearful of their condition, and they're really fearful about what they can do safely. Now, patients with lumbar-spinal stenosis are extremely sedentary, and this, coupled with their anxiety and their distress, can lead to a downward spiral. And in an elderly population, this can mean it leads to frailty and dependence. So why is this important? Well, we know generally that the better someone is going into surgery, then generally the better their recovery and their outcome is after surgery. And this really provides a very strong rationale for prehabilitation. So prehabilitation in other populations has been demonstrated to reduce complications, and with patients with lumbar spinal stenosis, there is evidence to suggest that it can improve physical function, improve mental well-being and their knowledge and expectations, and there is some preliminary evidence that it can also reduce length of stay and speed up return to function. You may have read a paper, a meta-analysis by Janssen in 21, that suggested that there was no role and prehabilitation was not effective for patients with undergoing spinal surgery. However, I would like to point out that exercise-based interventions and multimodal rehabilitation were excluded from the meta-analysis. So it was predominantly just about education, and I would suggest that that is not prehabilitation. I do acknowledge that there is limited evidence for prehabilitation, but just and we can do better, but I would say a lack of evidence isn't the same as no evidence that it is effective. So the final phase of where we think there's an important role for physiotherapy is in patients in the post-operative period for post-operative rehabilitation. So we know that surgery can be hugely beneficial and really helpful for the right person, but up to 40% of people report ongoing pain and walking disability, and 90% of people do not actually increase their walking after surgery. Therefore, they remain very sedentary and at risk of the negative consequences of inactivity. Patients report that their recovery can be unexpectedly long, arduous, and this really raises their anxiety that something's wrong. And they're typically discharged from hospital quickly. They have limited contact with healthcare professionals, and they're often provided with a leaflet with some post-operative advice, maybe some exercises. But they report that this is very generic, it lacks credibility, and therefore this reduces their confidence, their motivation to really follow this advice. So physiotherapy can help with all of this. And this was demonstrated back in 2014 with a Cochrane review by McGregor, who demonstrated that active rehabilitation, so exercise-based rehabilitation, is more effective than usual care in improving back-related functional status with a long-term standardized mean difference of 23%, low back pain by 18%, and leg pain by 21%. Now, subsequent systematic reviews have also demonstrated that actually multimodal rehabilitation, as Esther mentioned, that might incorporate cognitive behavioral training, amongst other things, can actually have additional benefits over the exercises alone. However, I do acknowledge that a lot of these studies are for fusion-type surgery rather than maybe the more decompressive-type surgeries that we see in this cohort. So I think we do have room for improvement here, specifically targeting the needs for patients, the older person with lumbar spinal stenosis. We do also have a further issue within physiotherapy. It's inconsistently provided within this country. There's also very much a variability about its contents. So we do require further robust research, really exploring the effectiveness of physiotherapy within this cohort of patients. So in summary, we think there's a strong role for physiotherapy in these 4 areas. But this shouldn't be in silo. We should all be working together as part of a multidisciplinary team with really good communication between physiotherapists and surgeons so that we get to see the patients in a timely manner. And this is all aimed at improving health-related quality of life for patients with lumbar spinal stenosis. Thanks.
Apologies that I'm not Rajiv Sethi. A rather poor replacement, I'm afraid. And what I'm going to give you is not the surgical view, but just one surgeon's view. Looks like you two have been communicating about this and it's giving the same message. So what's the role of physiotherapy in lumbar spinal stenosis? Well, this is my little big bugbear, which I'll just get off my chest to start with. And I think we've got to define lumbar spinal stenosis. And I'll give you just a few seconds to read this slide whilst I'm waffling on. But this is lumbar spinal stenosis for me. And Christine Comer, who I'm sure many of you know, came up with this definition, and I think it's an excellent definition, and I hope we use this for all the research going forwards. So I think that this is this sort of combination of bilateral leg symptoms, heaviness, weakness, made worse by standing and walking, and that the back pain should be a lesser component. Radicular pain can be present, and of course they can have radicular pain or cauda equina. So what's the natural history of lumbar spinal stenosis? This has just been covered, and not everybody gets worse. So about 50% of the patients stay the same, 30% probably improve over time, and maybe 20% get worse. And the only predictor of not improving over time is significant stenosis. So if a patient has on an MRI scan severe stenosis, then they're unlikely to improve from where they are at that current time. So we've already seen the three potential roles of physiotherapy in this condition. It can be used as a treatment, it can be used as prehab, and it can be used as post-operative improvement. And I agree, physiotherapy has got reasonable evidence of effectiveness in treating lumbar spinal stenosis. The duration of the symptoms and the MRI appearance do not seem to predict the outcome of surgical decompression, and that's really important for us. So if we send our patients for physio, we're not doing them a disservice, because this is not a time-dependent condition. And preoperative walking may predict post-operative walking. I think that's the only thing that we have in terms of evidence for suggesting why wait. The Cochrane review also points out the fact that you don't get any complications from physio, and surgery certainly does produce complications. So physiotherapy is a reasonable option for mild to moderate, almost tolerable symptoms. And these are all the guidelines. There's lots of them, and they all say the same thing. They all say that physiotherapy is a reasonable treatment option for patients with lumbar spinal stenosis. If we look at the indications for surgery, then non-tolerable symptoms and worsening despite physio is probably going to be our indication. There's quite a lot written on chronic cauda equina syndrome. It's probably an indication for surgery, but it's really hard to differentiate from age-related lower urinary tract symptoms. And of course, with our patients, we've got to be honest about the successes of surgery, and we need to weigh those up against the risks of surgery. And that's a summary of the risks. The ones coming from the NSIP database are actually UK live data. So those are our national figures according to our NSIP or HES data. Preoperative rehab is very easy. There may be a mild improvement, but isn't maintained a year after surgery. So patients who have prehabilitation or prehab do not seem to do better 1 year after surgery than those who don't. So that might be a cause for a little bit of debate. Post-operative physio, most evidence finds that post-op rehab and education do not improve outcomes after surgery, although there may be some evidence of benefit, as we've heard. So I think, again, I agree with Esther and Susie that more research is needed in that area. So my questions are, which patients are better managed with surgery? How much rehabilitation should we give these patients? And do these patients, do we get better value for money elsewhere? Sorry, my vision's not going a little bit. I can't read it from there. So are we better off giving different patients physiotherapy rather than this group of patients, given that we've got a limited resource. Thank you.
Floor is open to questions while you're making your way. I think you made a very important point about defining stenosis, and we have to be sure we are talking about the same thing. First question there.
Thank you. Michael Reddington from Sheffield. Firstly, happy birthday, Susie, today.
Birthday.
And the slightly less important thing, how do you make the decision as a physiotherapist with these patients as to when to send to Ashley? Is it the patient's quality of life, the patient's wishes, their walking distance, their MRI scans? So how would you both decide when to send a patient for Ashley's opinion?
Well, I guess for me, it's all of those things, isn't it? And especially if, I mean, we're talking about, I think you said intolerable sort of symptoms, Ashley, and I think that for me would be one of the things that would trigger that. If, you know, if they've actually given rehab a good go and their symptoms aren't settling, then, you know, people need support, they need help, they need to know what the other options are. And I think this is not around whether it's physio or surgery, it's about the right treatment at the right time. And, you know, certainly if someone's got deteriorating neuro symptoms, then that would be a reason to send them on. And I think, you know, sometimes I've heard people comment that perhaps physios will hold on to people for too long before they send them on. And I think it's also just everyone being aware of kind of what there is to offer patients and making sure that there is better joined up care as well. You know, if you're treating patients in the community, and in our trial we delivered rehab in the community, it's not that easy to get a patient in to see a spinal surgeon. You know, so actually there's issues with the pathway as well about how we get people in to be seen in a timely way. And if people are waiting, then what do we do with them? You know, we've got to provide support and care for these patients.
Yeah, I would agree. And I would also just suggest that one thing Ashley maybe said there was that I would say severe stenosis on an MRI is not a predictor of whether they improve, but severe symptoms and severe stenosis, they do appear to not improve by themselves, but they can have severe stenosis and very mild to moderate symptoms.
Yeah, I would agree with that. I think they need to have proper lumbar stenosis symptoms. The Wesberg paper was proper stenosis symptoms, but that's the only factor that we can use to determine whether a patient has got any chance of improvement on a natural history basis. I think the cord requiner thing is really tricky. I don't know what the surgeons think about that. It's a really tricky thing. I find it so difficult because this population have often got lower urinary tract symptoms. And you look at their MRI scan and they're sort of really, really, really tight, and obviously they've got leg symptoms. I don't think the radiology reports nowadays helps that, you see. No, it doesn't help. So that's a group that I kind of, anything where I'm sort of thinking this could be a little bit of chronic cord requiner, I tend to not refer those to physio. You know, clearly the pathway comes the other way, but they would be the ones that I would encourage the physiotherapists to perhaps send through maybe a little bit quicker. Don't know.
Thank you.
Aparajit Ulash from Preston. I agree with you, Kosh. It's very difficult, this chronic cauda with bladder symptoms. And from my own experience, I've seen some of them improve. So it's very difficult to know. I was going to make two questions. One is for the pre-op physio, another is the post-op. In the pre-op physio, is there a standard? Is there a defined physio? Because from my experience, patients go and they say, it was a waste of time. I went, they just gave me a talk and then gave me this leaflet to do, which I knew already and didn't help me at all. And post-op wise, I see them say 8 weeks, 10 weeks later, and they come and say, oh yeah, I'm waiting physio, I've got an appointment next month. So it's 3 months down the line. Both of these defeats the purpose, isn't it?
I couldn't agree more. So if we look at the Janssen systematic review where they said that pre-op physio didn't work or prehabilitation, they were just educational-based programs predominantly. And so I think we have to define what prehabilitation is, and there's been a big project going on at Exeter with Leanne and with Esther here. So about what are the essential components and who needs it as well, because we probably shouldn't just think of a blanket provision for everybody. And yeah, so education and pre-assessment is not the same as prehabilitation. And I think we have work to do there. And yeah, again, 8 weeks down the line, 12 weeks down the line, several months down the line, we're setting physiotherapy up to fail almost at that point. So the patients tell us they want it in the early preoperative period. That's where they're struggling. And that's where maybe they can make the biggest improvement as well. And if we look at the girth pathways, they suggest that patients are accessing physio a couple of weeks after surgery. And I would suggest that for all maybe the surgeons in the room, maybe you could support the physio colleagues at trying to get that pathway in place where you're working, because I think there's a huge problem there.
Could I ask a question?
Where is...
Back here.
Who's talking?
Sorry, from the dark. Shivan Maria from Manchester. Susie and Esther, just a bit further into Mr. Golash's question. When you say multimodal physiotherapy as a prehabilitation, if I'm seeing a patient in clinic and I'm saying, right, I think you could benefit from some physiotherapy, what is it that actually entails? What are is it you mentioned education. Are you doing pain relieving methods, TENS, or is it exercises alone? Could you just shed a bit more light? And again, is there like a set regime that you have, or is this variable where it's going to be a wide variability in practice between different physiotherapists?
You go. You've done all the work in this. I might have something to say though.
So they talk about prehabilitation as sort of being a triad of mental well-being, physical function, and nutrition. Just a complete mind blank there. So we should be considering all of those different aspects. So with nutrition, it should be about a high-protein diet, not just weight loss, where they will lose muscle bulk and further move into frailty there. So mental well-being, that's psychological preparation for surgery. There's some very good evidence to support that within other cohorts, within other populations. And then the physical function, so doing strengthening, balance, and cardiovascular where they can, or increasing their walking is really important. But we don't have a standardized program. I think there should. I've been researching and trying to develop one, and I think that that's a really exciting and important area to develop in the future. But we've also got to be very important. An important distinction is it's not the same as the physiotherapy that they had maybe before they were referred to for surgery. So prehabilitation is not the same as conservative care, because I think that's a very different message. So patients are like, well, I've done physio, it didn't help, and that's why I'm now going to see surgery, to see a surgeon. We need to say this is going to help you prepare for surgery. The better you are going in, the better you are coming out, the better the improvement and the less chance of complications. So it's about really selling that as well to the patient.
And one thing we haven't talked about, I think, is that this patient group will be, they can be extremely deconditioned, they can be frail. Issues like sarcopenia are really important as well. A lot of these patients are elderly, they will have age-related muscle loss, which impacts on their ability to mobilize, and they can get in this downward spiral of mobility where it's a combination. It's the pain, it's the inactivity, it's the loss of muscle mass. And actually thinking about that from a nutritional perspective in terms of building muscle mass before surgery and in optimizing their sort of muscle strength also is a really key, I think, element of prehab as well. And it's working out how within the sort of constraints they got of their pain that you could support them to exercise and maximize their physical capacity going into surgery.
We'll have final two questions, one from here and the second one up there.
I'm Ras Sundram, orthopedic spine surgeon with Cheltenham and Gloucester. So I think my two people have asked my question already. But again, the role of physiotherapy, one of the, I see in clinic, patients say, what exercises should I do? Okay, but I think you've answered that in terms of it's not just one, it's all about different conditions, things like that. Okay. The other thing that I wanted to say is like the people with like severe stenosis and severe tightness. I mean, I have seen quite a lot of people, especially over the COVID period when lots of surgery was cancelled, those people have improved. So I don't know how accurate, what percentage of people with severe stenosis and symptoms do improve. But I do see people who have improved. I can name patients myself. They were absolutely critical stenosis. They have improved.
It's about 30%.
Who will
symptomatically improve. That's the natural history of the condition.
No, even with severe stenosis and severe...
Yeah, even with severe stenosis makes it less likely that you will improve, but it doesn't make it zero. So it's probably a lot less than 30% if you've got severe stenosis. But given the whole cohort is 30%, it might be 10% or 5%.
Yeah.
Just makes it less likely.
Right, thanks.
Go ahead.
Thank you very much. Lisa Roberts from Southampton, and thank you for a great presentation. I just wondered if any of the panel had got any pearls of wisdom about what spine surgeons can say when they are talking about patients going to physiotherapy. We know that what the surgeon says is really, really, really important, but how that message is delivered and what's going to happen in physiotherapy is hugely important. And we know comments like physioterrorist and all the other things are kind of not helpful. So I just wondered if you had any ideas of what's the best way to optimize that transition to physiotherapy. Thank you.
Yeah, what a fantastic question. So I want Ashley to answer the first bit, but I also have heard both sides where surgeons say to the patients physiotherapy is useless, and physiotherapists have said to patients surgery will paralyze you. So I need to hear both sides.
Yeah, I think it's really important, patient messages. I mean, obviously the wrong thing to do is to say physiotherapy is a complete waste of time, but I'm going to send you there anyway. So you've obviously got to big up physio, you know, and tell them that it's more knowing that the condition is not time dependent, that they've got time, they've got a reasonable natural history, and that physiotherapy actually works in a large number of patients. And if the patient sat in front of you, you know what surgical procedure you would do, all right? So tell them about that. Say, look, the surgical procedure for you is a lumbar decompression, and these are the success rates, and these are the risks, all right? They're sat in front of you, why not? And then they know, they might go into the physio a little bit more enthusiastic about trying to avoid your surgery, because your success rates are not 100%, and the complications are significant.
And I would also say that as part of your conversation, you can say things like, you know, the evidence we've got from clinical trials, like our BOOST randomized controlled trial, which I'll talk about tomorrow if anyone wants to come, is that actually we showed that we could improve walking, we could improve physical capacity, we could help people cope with symptoms. We didn't help everyone's pain levels, and we acknowledge that, but I think you can then say, you know, the physios can show you how to manage these symptoms, they can show you how to improve your walking, they can show you how to get fitter, you know, and actually kind of sell the benefits that actually we have seen from rehab as well. And some patients do get improvements in pain, but I think actually setting expectations for rehab is really helpful for patients to say, this is how we see that rehab can help you. And I think that also helps when patients come along. So in BOOST, we actually excluded people on surgical waiting lists. And partly that was because we didn't know what conversations surgeons were having with people. You know, are they going to send them to rehab just saying, we're going to try this, it probably won't work, and come for an operation? You know, and then actually, you know, you've got someone that's not engaged in the whole rehab process, and that makes it really challenging then to you know, to help that patient.
Thank you. I think we'll call it a close, because at 11:15, I think we are back here, so you all have 15 minutes for drinks. And if you have any further questions, I'm sure you can catch the panel over drinks.